Ladies and gentlemen, welcome back. Now we will move on towards our second scientific session for today. I would like to invite the chairman for this second session on stage, that is Professor Dr. Abdul Ghani Pathan. Sir is an ex-professor of operative dentistry LUMS and is an ex-principal Bhitai Dental and Medical College. Sir, may I kindly request you to join us over stage. Next, I would like to invite the co-chairperson for this session, that is Professor Dr. Subuhi Ghani. Ma'am is Professor and Head Department of Orthodontics at ISRA Dental College. Now I would like to invite the moderator for this session, that is Professor Dr. Salman Shafiq. Sir is Principal, ISRA Dental College, Hyderabad, and also heading Department of Oral Maxillofacial Surgery at ISRA Dental College.
Second one. Right. Assalamu alaikum. So I think, so Dr. Feroz, shall we start? Okay, fine. So I'm Dr. Salman Shafiq, Principal and Dean, Faculty of Dentistry, but by profession I'm Professor in Maxillofacial Surgery at ISRA Dental College and ISRA University. So thank you, organizer, for providing me opportunity to moderate this session. It is wonderful and amazing field with the pleasure and pride to be in alma mater and chairing the session with the respected teachers. So the first speaker for this session is Professor Nasir Salim. He's going to speak on restorative management of anterior aesthetics. Nasir Salim Saab is Principal, Raber College of Dentistry. He is FCPS in Operative Dentistry and a Master's in Aesthetic and Restorative Dentistry from University of Manchester, UK. He is a Fellow of Dental Surgery at Royal College of Physicians and Surgeons, Glasgow. Currently, Principal of Raber College of Dentistry. He is also a US and a Pakistan patent holder, and active PhD scholar. So I invite Dr. Nasir Salim for his speech. Please, sir.
Sir, thank you so much. Bismillahirrahmanirrahim. Assalamu alaikum, everyone. वैसे सुना था सर्दियों में चीज़ें सुकड़ जाती हैं, मगर चाय के बाद ऑडियंस इतनी सुकड़ जाएगी ये मतलब उम्मीद नहीं थी। चाय ज़्यादा अच्छी है ना? चेंज हो गया। या, that's it. कहाँ से? ये वाला बटन दबाएंगे ना? तो वो आ नहीं रहा अभी। ऊपर वाला दबाएं। एक मिनट। आप अब करें सर, अब स्लाइड यूज़ ऊपर वाला? Okay. First of all, Dr. Professor Abdul Ghani Pathan, sir, I am so glad to meet you for the first time. I was just saying to Farhan, you come from our field, so please have a seat. It's such a pleasure and honor to present while you are chairing the session. I come from the same field as you, but it's my loss that I had never met you. So I'm grateful. I'm grateful to Professor Feroz Ali Kulhodo. Thank you so much, sir, for the invite and all the organizers who have put up a wonderful show. This is what we are going to talk about today. It's no rocket science. We're just going to talk about some of the basics that would get you while you are restoring the aesthetics in the interior area. What are the various steps? What are the small little tips and tricks that would help you achieve a more predictable outcome every time? Whenever we are taking up a case, whether in the aesthetic area or generally something that requires a full mouth rehabilitation, the first and the foremost thing is, a sound diagnosis. And for the sound diagnosis, of course, you need to take the clinical history, you need to, go for the clinical examination and stuff. But documenting that is equally important. I think we can take a leaf out of the orthodontist's book that they really document their cases well. And now I see a lot of residents as well as faculty in operative dentistry as well documenting the case as well. It does not only have a potential, or it does not only have an advantage while you are presenting these cases for educational purposes, but legislatively also, when you are treating these cases who are very, very aesthetically conscious, you need to have a starting point documented that you can show the patient later for them to have a comparison of where you started and where you ended. And I think it has a great value by delegating that responsibility to somebody, probably an associate in your clinic, maybe a fellow a resident at your institutions, to do that for yourselves. So for example, in this particular case, if you do not go with the electric and the vitality pulp testing, some other colleagues of mine in the first session also talked about that, you may actually miss that there are certain teeth that are actually non-vital and require endodontic treatment. There's another tooth here, of course, that has to be compared with a tooth from the opposite side. Again, document these things in the patient's records, whether you keep it electronically or you keep it in the hard copy form. Then taking good radiographs and keeping a record of them is again extremely important. This is that tooth that was deemed non-vital while we were checking the electric and the cold testing. Similarly, this is the tooth that was deemed to have irreversible pulpitis. So it helps you formulate not only the treatment plan, but also the sequence of it, like which things need to be addressed first and then which need to be addressed a little later. When I am talking to my postgraduate residents, I think the most important thing for cases like these is to have articulated casts. And then if you don't want to go for the digital mock-ups or stuff, please go for a wax-up. My lab guy charges me 500 rupees per tooth for a reasonable and a very good wax-up. And wax-up is your starting point. It shows you, or your patients, as it show you along the way, where you would end at once you are done with this particular treatment. Okay, now once the documentation is done, the next big step is planning. Within the treatment planning, sometimes we do not give the pink aesthetics as much importance as it should be given. For example, if you look at this case, even if I was able to do some of the best dentistry in this patient's mouth, I would not be able to create a good aesthetic result as long as I do not bring these margins equal to the canines over here. Now, the canine does not even look like a canine. It looks more like a lateral. So you need to adjust the gum margins. Otherwise, no amount of a wonderful dentistry, aesthetic dentistry, is going to bring this patient into any semblance of normalcy that we are going to or trying to give this particular patient. So you need to do the surgical mock-up. Then use whatever, the gadgets are out there, choose gauge and stuff. Then go for your crown lengthening procedures. And once you are done with that, it's extremely important to hold this now with some really quality interim restorations. And I think CAD-CAM temporaries are just a blessing. So if you can just keep this patient in CAD-CAM temporaries, once you have prepared, look at how the gum margins were at the outset and how they are once we have prepared them for the interim restorations. And once interim restorations are in place, they will provide a wonderful medium for gum to grow around these restorations. And there's nothing that gives me more pleasure than when you take these temporaries out, there's such a wonderful collar of gum around it. The research says that you need to, wait for about 6 to 9 months. Generally speaking, in private practice, I would wait 1.5 months. Patients do not have that much time, even for the aesthetic region. So this is what we started with. This is what we finished. So whenever, from this point onwards, as young residents, you look at a case from an aesthetic perspective, I want you to have a look at the gums as well. And sometimes people do wonderful veneers and say, it still doesn't look good. And the reason is that they've been unable to identify the discrepancies in the gingiva and address it, and hence they do not eventually end up with a really good result. Then at the very start of treatment, if you have got teeth that have got, a lot of discoloration associated with them, I'll show you this case right down till the end. Right now, I'm only explaining to you or emphasizing that if you need to give this patient veneers, and with so many people around, orthodontists, if the patient does not choose orthodontics and you have to treat this case restoratively with veneers to bring them back into their alignment, then another important aspect is first lightening these teeth up by virtue of providing bleaching, vital bleaching to this patient. Again, these things should not come as an afterthought. They have to be planned meticulously at the start, just like pink aesthetics. So adjunctive treatments के अंदर आप you can go for probably bleaching, you can go for microabrasion. There are so many things that you can do to lighten the teeth up before you take them to the final restorations. Okay. Then two more things in treatment planning are the mock-ups. So this is a patient of mine that came for veneers, but once you are doing a consultation for the veneers, the patient would like to feel something or see something in their mouth as to what the final restorations would look like. And for that purpose, a wax-up, which I told you probably would cost you somewhere around 3,000, 4,000 rupees from a reasonable lab, then taking a putty impression without the tray, creating these V-shaped notches so that the bisacral composite that we are going to use for this particular mock-up can escape from, and you can actually carve it out. And then using this to actually create a mock-up in the patient's mouth so that she has something to look forwards to. And you can give them not only the form of the teeth, but you can also give them exactly what kind of shade the teeth would look like at the end. So I generally, when I ever talk about, I talk about the things that are available in Pakistan, easy to use, cheaper solutions for our population, and something that our residents can do. You can always go for a digital smile design, you can always have it printed, you can have it in the patient's mouth. Probably 4 to 5 times more expensive, getting you pretty much the same result. Okay. Then you can go for digital designs. Probably Prof. Hina is going to touch a little bit more about that later. The same wax-up can actually be your preparation guide as well. So now that I have made the preparations, this horizontally placed putty cut as it should be cut, placed on the teeth, cut teeth, can give you an idea that you have actually cut exactly how much is required so that the lab guy can make a really well-contoured restoration for this particular patient. Again, cheaper, but it's got excellent value when it comes to clinical practice. Okay, I'll just very quickly go through some of the basic principles of space management. Again, with due respect to all the orthodontic colleagues, we go for such options once the patient says, I do not want to go the ortho way, I do not have the time, resources, or patience, maybe, and I would like to manage this restoratively. So if you've got a really small diastema, about 1 millimeter, and your teeth are as they should be, which is 1 millimeter longer than the lateral incisors, the centrals, then you should not change anything. Just add that small bit of 0.5 millimeter into both the teeth, and you would have your diastema built up perfectly fine. The problem is when this diastema increases, because you need to keep that proportion of the teeth in mind. So now, if nature helps you and your teeth are already at a higher level, like probably at the level of the lateral incisors or much lesser, then you are helped by nature to actually increase the length and the width, and you still keep the proportion alive. But generally speaking, we are in a situation like this, where teeth are in their ideal position, in terms of their incisal edge. However, we have got a big diastema in the middle. So now you need to take the burr, cut distally, cut distally. We are doing orthodontics now, but a slightly more aggressive one, a restorative one. So we are redistributing space. And all this space created will now be distributed rather than wholly solely here. Now it will be distributed in all three teeth, and you would have really nicely proportioned teeth as it should be for the patient's acceptance. Okay, I'll just quickly run through it. This is a case. Have a look at this. It's a reasonable nightmare, a flattened papilla, a large space in the middle, space on the distal of the canine, and it's really spacing everywhere. Probably, I think he was an MBBS graduate while I was in CMH. Again, you start with your wax up. This is your guideline. You use the putty matrix, and then you use that putty matrix to redistribute that space by cutting in some critical areas. We are unable to manage this black space, but it's a very reasonable outcome from where we started, which is probably 2 visit appointment. That's it. And you are bringing the patient from where he was to where he is now. But this cannot happen in the patient's mouth. This is first going to be done on a cast, then the wax up. And when I am asking someone to do the wax up for me, for example, the lab, I would ask them, when you cut the model, please make a copy of the cut model as well. Then do the wax up and send me the wax up, because whatever he has cut, like if he has done cutting on the mesial of the central incisor or the distal of the central incisor, I should know about it so that I can mimic the same cutting in the patient's mouth and then transfer that wax up into the patient's mouth. So, good tip. Always go for the wax up and also get the cut model copy to you from your lab. Okay. If you've got crowding, the same case that we had lightened up, you need to remember कि जब कभी भी आपने किसी दांत की इंसाइजल पोजीशन को रेस्टोरेटिवली चेंज करना है तो अब आपको इंसाइजल एज रिडक्शन फॉर वेनियर ज़्यादा करनी पड़ेगी. अगर नॉर्मली आप 2 मिलीमीटर्स करते हैं तो अब 3 या 4 मिलीमीटर्स तक आपको कट करना पड़ेगा. And that is pretty evident in the kind of reduction we do in this particular case. I'll just run through it so that doctor, you are, you know, I just want के ये जो ऊपर चल रहा है ना, this is
the correct timer.
okay.
You have
11. Oh, lovely. Thank you so much. जैसे वोट को इज्जत दो, टाइमर को भी इज्जत दो. So I will try my best to, you know, finish within time. So now if you see the teeth that were out of position, we prepared the central incisor much less. Okay. This central incisor about 1.5 millimeter reduction. This is about 3 millimeters. This is 4 millimeters. Why? Because I need to bring this tooth back into the arch. And once you have done that, you can come from there to here. So nothing happens without having that particular knowledge in your mind. Dentistry or good dentistry does not happen by accident. You need to plan it, and all the planning happens on the models, cast, photographs, discussions with your seniors, and then you need to execute that into the patient's mouth. Had I not bleached these teeth, the results would not have been as good as these. So you need to be very careful when you are doing such aesthetic cases. Okay, when you are managing wear, हमें बचपन से पढ़ाया गया था इंसाइजल एज को 2 मिलीमीटर काट देना है, तो एक दफ़ा मैंने बर पकड़ी काट दी, पता चला वो इंसाइजल एज तो पहले ही शॉर्ट थी. So in this particular case, if you've got already a worn central incisor, then probably I don't even need to cut this tooth in the incisal region. I just need to flatten it out a little bit to have that butt margin that we need for our veneers, and then do the rest of the preparation. Have a look at where the canine is. So I, you know, sometimes forced by the, you know, by the habits, we tend to just go by whatever was told to us, and we start cutting from the incisal edge, make the margin, do the facial cutting, only to know that we have cut more than that was desired. So for this, my preparation looks something like this. I have just flattened out the incisal edge a little bit and no more reduction. If I cut 2 millimeters, I'm already cutting too much. And just by this, I would be able to recreate the kind of anatomy that I require for this particular patient, the kind of, incisal relationships with the canine that I need to do. Of course, this patient could have, benefited by having her premolars veneered as well, but then cost is an issue, and sometimes patients opt for as much as they can afford. Okay, communication to dental lab is extremely important. मुझे याद है कि हम ग्रेजुएट कर रहे थे तो एक वीटा की शेड गाइड लेते थे, और मेरी तो वैसे ही मुझे रंग ठीक नज़र नहीं आते, तो आई ऑलवेज आस्क सम lady or an associate or another dentist at my practice to actually take the shade for me. Some of us are colorblind, so जो shade लेने के basic principles हैं, I would not like to doubt your intelligence, all of you know them. I would just focus on the fact that photographs are probably one of the best ways. Well taken photographs are probably one of the best ways to communicate whatever you want to communicate to the lab. But एक चीज़ जो वो नहीं communicate कर पाएगी, or you can use the electronic shade guide, really good system, Ivoclar का आता है, you just put it onto the tooth and it will give you both the 3D shade guide वाला shade and the other shade. And it's reasonably accurate, really nice results. What is not visible, or what you should communicate and sometimes is not that visible with the written communication that you do, are the presence of these line angles, these transition line angles, because as light bumps off these line angles, how tall, small, wider your tooth is, it is visible over there. Okay? So you need to send really quality pictures, then maybe draw a diagram, take shades at different places, and then send it to the lab. If you've got some white spots at some places, then put some white spots in those places for you to actually give it. And our lab guys are really good. At least har shahar mein 1 or 2 labs are of that quality who can give you the results that you desire. और अगर फिर भी मसला है तो आजकल स्कैनर्स का दौर है, आप दुबई भी भेज सकते हैं. We work with a Dubai-based lab. I'm trying to establish a communication with an Ireland-based lab, और charges थोड़े से बढ़ जाते हैं, मगर the results that you get can be wonderful. So once you communicate this well, then you end up with results like this. It's the same case whereby we have actually veneered these lateral incisors, but the kind of anatomy that we have been able to inculcate really does not feel like that these peg laterals have been transformed into the kind of restorations that there are now. Thank you so much, sir. Or this is from another angle. Okay, so I'll be left with some time. Would I be paid for it? I should be. Anyways, so no, dhamaka वैसे was working. ठीक है ना, शेडी आपकी दफा उन्होंने धमाका नहीं किया ना, the bump does not go off. Should have. Okay, so but I really enjoyed your presentation. Wonderful. So clinical follow-ups are important. This is one of my PG's cases. Very, very difficult case. It's heavy fluorosis patients. यहाँ पे मैंने इसका clinical result दिखाने के लिए नहीं रखा है. I have basically put this here that these 2 pictures are 4 years apart. So you need to bring your patients back in for the follow-up. Sometimes it's not like do the treatment and goodbye. When you do this much of clinical work or restorative dentistry in a patient's mouth, it is imperative, it's important, it is absolutely essential that you at least give them a call. और हमारी practice का एक असूल है कि if we give a call, it gets documented on the patient's forms electronically or manually that Mr. So-and-so was called, did not attend, did not want to come for a follow-up, took an appointment and did not come back, because मैं भी भूल जाता हूँ और हमारे पेशेंट्स आके हमेशा शिकवा ही करते हैं कि आपके ऑफिस से कॉल ही नहीं आई थी तो इस वजह से हम तशरीफ नहीं लाए. So it's always documented. So this patient chose to come after 4 years, but it's important, and you can see the difference between the 2 pictures, the build-up of the plaque and everything. But the gum is in reasonably healthy condition, so he was given the regular prophy and was sent back. But this clinical follow-up only is not important. You need to go at times for the radiographic follow-up as well. And look at how neatly these margins correspond with these veneers. If I'm doing a restoration that is going onto the proximal surface, I would like to take a radiograph. Please do take radiographs. You will be amazed at the things that you see. Sometimes some not so pleasant. So this just brings me to the end of my presentation. To sum it up, always look at a case with a very astute eye. The way I looked at my cases maybe 15 years ago is very different from how I look at them now. But look at the pink aesthetics. Go for a good diagnosis. Do all your cases first on the wax-ups. Bring it back, recreate it in the patient's mouth in the form of a mock-up. Discuss your case with your colleagues, seniors, to see if any change or modification in the preparation is required. Because once you put the handpiece to the tooth, it's irreversible then. Or bazokat, I would ask my resident to make an exact kind of preparation if they are going for a big veneer case, to make the exact kind of preparation on a phantom head, show it to me. And then maybe the next day we can go for the clinical case. So just be prepared, take good follow-ups, and yeah, that's it. Thank you so much.
Thank you, Dr. Nasser, for giving us insight. Dentistry and aesthetic goes hands in hand, and things becomes even more important when it's for anterior teeth. So diverse cases with impressive aesthetic outcome. So the next speaker is my inspiration as an undergraduate student. I'm talking about Professor Atiya Sheikh. She's going to touch upon adversity of technology. Her topic of speech is Tech, Neck, and Skeletal Malocclusion, a modern orthodontic crisis. Dr. Atiya Sheikh is professor and head of orthodontic department at Liaquat College of Medicine and Dentistry, Karachi. She also holds the credential of being the first Pakistani ambassador for American Association of Orthodontics. She also has the credit of being a faculty of examiners for MFDS examination by the Royal College of Surgeons of Edinburgh, London, and Glasgow. And she is recognized as one of the pioneer orthodontists in Pakistan, and I'm the witness. So, Dr. Atiya, please.
Isn't हाथ से चेंज करना? इसे ये pointer? Okay. First slide. नहीं तो next करने के लिए ये करना है? Okay. Bismillahirrahmanirrahim. I am Professor Dr. Atiya Sheikh, currently working as head of the department, consultant, and director of orthodontic residency program. Today, topic of my presentation is Tech, Neck, and Skeletal Malocclusions, a modern orthodontic crisis. So, modern technology and advancement, in like every field of dentistry or medical sciences, it offered huge benefits like vast information access and instant global communication, increase efficiency and better healthcare. So similarly, in orthodontics, the modern technology has brought drastic changes. And AI tools and many others, which I'm going to discuss afterwards. But these modern technology, they are there to increase the efficiency and to improve the comfort of the orthodontic patients through biological and digital innovations. So, many modern technology and procedures like intraoral scanners, digital models, digitizers, eye tools, CBCT, they all help in diagnosis, treatment planning, and they have brought many improved changes which help us in prevention and the plannings. Okay, so no one can deny the role of habits in orthodontics. Many bad habits like thumb sucking, tongue thrusting, clenching, these all habits, they play a major role in the development of the dentofacial complex. And whenever they disturb the development, definitely it causes maybe dental or skeletal malocclusions. So in orthodontics, it is very critical to identify these habits, so to get the better results and to get and decrease the risk of relapse. Okay, so modern habits, modern world, modern habits. And these modern habits are called tech habits. We use mobile devices and laptop screens every time, everywhere, at work, at school, and we spend all the day. And that definitely affects our life. So, do you know that these modern tech habits can cause dental problems? Trust me, it looks strange, but it is real. It can cause the neck pain and the shoulder pain and the headaches, and then it can stretch to the jaw pains and dental issues. So, like everyone knows that modern technologies, and it has a major role in our lifestyles. It modifies our lifestyles, and it affects our productivity, our well-being, and our overall health. So modern technology, it has positive effects. It has made positive effects in the world, but we cannot deny that these modern technology has adverse effect if it's being overused. So posture plays a very important role in all other fields of dentistry, but mainly in orthodontics. Whenever the patient is sitting in a bad position or using its devices for hours and hours, definitely it leads to the neck pain and shoulder pain and temporomandibular joint disorders and dental and orthodontic health. So in today's presentation, I'm going to explore that how this posture affects the orthodontic health. So we spend many hours tilting down our head and altering our neck posture. So this is going to affect our posture, and this posture is causing strain, and these are called tech necks. So tech habits causes tech necks. So what is tech neck? The term tech neck or tech neck, basically it's a tech neck syndrome if we are discussing about the whole body, but if we are concentrating only on the neck, then it is mainly called tech neck. So the term tech neck is used to describe the potential damage brought on by spending a lot of time gazing down at a cell phone or other wireless devices. So before going on details, we should understand first what is the impact of modern technology and poor posture on our neck, and you getting caught up with it and ending into a vicious cycle. So let's take into the, briefly, let's discuss the anatomy first. Okay, so the head, cervical, vertebra, and mandible, they all act as one single functional unit. And that is called the cranial cervical mandibular system. So this upper cervical vertebra is basically divided into two parts. The upper part is closely linked to the craniofacial development, and the lower part grows in conjunction with the rest of the vertebrae. The temporomandibular joint and the occipital atlas and axis, these vertebrae, they are separate bones. They are only connected with the muscles and ligaments. So cervical posture is basically directly linked to the cervical morphology, and to the nasorespiratory function, and thus this influences the cranial development and overall development of jaws as well. So the altered posture creates muscle imbalance. So whenever the head position is forward, it leads to the lengthening of and weakening of the deep cervical flexors. And it affects the stretch of the sternocleidomastoid muscle and the trapezius muscles. And this affects the posture and overall the development of the jaws and craniocervical extensors. So according to the soft tissue stretch hypothesis, which was produced in 2002, it was said that the positional and functional competency plays a very much role in the development of the craniocervical region. So whenever there is morphological change, it causes obstruction of airways. And whenever there is airway obstruction, it affects the neuromuscular feedback, which is sent to the which causes postural change. And when the posture is changed, there is a soft tissue stretch, and this soft tissue stretch will exert forces, differential forces on the skeleton, and finally the morphological change is there. So whenever we spend many hours tilting our head downward, as I said, this tech habit causes tech neck. So normally a human head, it weighs 10 to 12 pounds whenever it is held in a neutral position. But when we tilt our head downward, this posture causes this effective weight. It causes drastic changes in the cervical spine, and it brings the changes which are maybe permanent. So can you imagine at 60 degree of forward tilt, there's a pressure of 60 pounds on the cervical spine. So for every inch our head moves forward, its effective weight on the spine increases by 10 pounds. We never realize. We really spend many hours on our phones. So this constant strain does not limit itself to the spine. It is extended to our jaws. I'm again and again talking about jaws because that is our concern. Okay, so according to the study which was done in 2017, it was said that 79% of people aged between 18 to 44 years, they are using the mobile almost all the time. And then in 2022, it was said that 50% of the global communication, they uses their smartphone for around 2 to 3 hours. But now, it is said in 2025 that more than 80 to 85% population is using mobiles for more than 4 to 4.5 hours. And this, definitely this is increasing every day, and it is affecting our behaviors, our habits, our lifestyles, everything. So, as technology evolves, so does our interactions with it. So, what is the impact of tech neck? To summarize, tech neck affects the posture, and that posture causes a strain to the neck and the shoulders and causes headaches. And this strain is then extended to jaw, causes sensitivity of teeth and developmental disturbances of temporomandibular joint as well. So let's go in detail that how tech neck affects it. Okay. So tech neck is basically spine is the pillar of our whole body. So whenever there is any disturbance in one area of our body, they all are interconnected. It causes some problem in the other part of the body. And the jaw is no exception. Here you can see that tech neck can cause the muscle strain and pain all over the body. It even can cause the pinched nerve and numbness. And the cervical disc degeneration is there because of the neck pain and stiffness. And surprisingly, the lung function is also disturbed. So in our clinics, we frequently see patients, they come to us having the mandibular and having the temporomandibular joint disorders, having jaw pains, and this is most of the time, the stem is because of the prolonged use of devices. And whenever the jaw is affected, it causes malocclusion, it causes clenching, the wearing of crowns, the wearing of teeth, and sensitivity is also there. Okay, so the cervical spine and the mandible and the cervical vertebra, they act as a single unit. So whenever there is forward head posture, that forward head posture causes the tongue to be in the lower position. And whenever the tongue is in the low position, it causes, it affects the airway and causes mouth breathing. So airway is compromised. And when airway is compromised and patient is in a growing phase, it will cause the malocclusion or skeletal malocclusion because the craniofacial growth is altered. And this may lead to the TMD and the myofascial pain. And even the sleep disorders, breathing, obstructive sleep apnea may result. And again, if there is obstructive sleep apnea or mouth breathing, this can affect the forward head posture. So it's a vicious cycle where each component reinforces the other. So briefly, the impacts of TechNEC are broadly divided into oral and dental impact and general health impact. So the link I have discussed, and for general health impact, they need to go to the chiropractors and physiotherapists, and for oral and dental impact, they need to visit orthodontist. So I think everyone is now believe that does the position of the head and neck make a huge difference on the occlusion. So what happens whenever forward head posture is there, muscle imbalance is there because of the overactivation of the neck muscles and weakening of the posterior muscles. This will alter the jaw position and this will result in the malocclusion. So this is the link which is important for us. So the posture and the skeletal malocclusion, the relationship is bidirectional. The posture may cause the skeletal malocclusion and the skeletal malocclusion has a great impact on the posture. So it's a chicken and egg situation. Stand up straight, stop slouching. Parents and grandparents, everywhere, they keep on saying this to their kids and teens. हमने बचपन से सुना, हमें पेरेंट्स कहा करते थे, सीधे होके बैठो, बिस्तर पे बैठकर नहीं पढ़ो, स्टडी टेबल पे बैठ के पढ़ो, झुक के नहीं चलो, नीचे क्यों, एक टिपिकल वर्ड को निकाल कर मत चलो. और you know what, they were and they are still right. They're still right. Because not for the reasons we all are thinking that it will affect the spine alignment, ya bachcha jo hai will look more confident and attentive, but also, again, the jaw development. So there's a strong tie between the jaw development and the position. So whenever the patient is in the growing phase, this altered posture, जब आपका head down होगा, your mandible growth is hindered, and this will result in skeletal class 2 malocclusion, where the mandible is small. And if the patient is not in a growing phase, तो definitely skeletal malocclusion तब तो नहीं हो सकती. So adults having different symptoms like headaches, even earaches, and numbness, nerve disc issue, which I have already discussed. So, like the posture can affect the skeletal, can cause the skeletal malocclusion. Skeletal malocclusion, as I said, can affect the posture. Patients who are having skeletal class 2 malocclusion means small mandible. They tend to keep their head upward. Their craniocervical angle is increased. Here you can see their the craniocervical angle, the class 2 patients, their craniocervical angle is increased. What they do, they have small mandibles, they tend to extend their heads like this. This improves the airway, and they tend to hide their defect or problem. They try to compensate for the jaw position. But on the contrary, in the class 3, they have strong, large mandibles, prominent mandibles. So what they do, they consciously, they keep their head tilted down so that उनका जो mandible है वो इतना prominent ना लगे. So even I did a research 2-3 years back, which was published in International Journal of Orthodontics, in which it was the research which showed that even just looking at the cervical spine at a glance, we can tell that what type of malocclusion is there. Skeletal malocclusion. We don't need to do the tracings and doing the SEF. So similarly, the skeletal class 2 malocclusion, the patient posture is also changed. This causes the upper body to move forward, and the class 3 patients, the upper body जो है वो backward होती है. So this is an unconscious effect जो वो subconsciously कर रहे होते हैं, even उनको पता भी नहीं होता. So the skeletal class 2 or class 3 malocclusion does not only affect the neck posture but also the body posture. So orthodontists are definitely, they are mainly concerned with the tech neck. Why? Because of all these reasons, which I've already discussed, but impact on the orthodontic treatment. If, for example, if patient is already under orthodontic treatment, or if that patient is not keeping his neck or posture normal or proper, not in the right position, so what will happen? Definitely this is going to hinder our orthodontic treatment. It will cause, there will be increased chances of relapse. हम उनको functional appliances दे रहे हैं, हम उनकी growth को, for example, mandible short है, हम उसको आगे कर रहे हैं, and their posture is causing the mandible to go downward or backward. So this will just, counteract with the treatment. Okay, so if forward head posture is a health problem, why do we tend to ignore it? हम में से कोई भी अपना स्मार्टफोन्स को यूज़ करना नहीं छोड़ता. हम इसको इग्नोर कर रहे हैं इस प्रॉब्लम को. And why it is so? Maybe because it's gradual. Maybe because pain does not appear immediately. Maybe it is considered as tech normalization, where everyone presumes that everyone is doing it. What's harm in having this type of posture? Maybe like pure Pakistanis, we always try to ignore things till the functional issues arises, like dental crowding. जब तक हम खाने पीने में प्रॉब्लम नहीं है, हम क्यों अपने दांतों को ठीक कराएं? That's what the concept is. So we all ignore it. So have you even thought about it that you are having this posture? This is your neck? Do you really spend hours and hours on your laptop screens and mobile screens and tilting your head downward? Do you clench your jaw while replying to your notifications and deadlines? You're stressed? Or maybe, have you ever noticed that you are using a mobile and you are breathing through your mouth? Or maybe you chew your pen or pencil when you are stressed and you are even distracted. So this we all have to take care. If any of these things you are doing it, you are having this posture, you need to stop it immediately. So because you need to protect your spine, we should avoid tech neck. We need to modify our habits. The scariest thing is this, that we are doing this bad to ourselves. And the good thing is this, that we can fix it by doing some consistent, conscious habit changes. So we need to guide our patients that we should adopt healthy digital habits, and this will decrease the risk associated with the excessive device use. So small changes can bring significant long-term benefits. So we all should follow the 20-20-20 rule. हर 20 मिनट बाद 20 फीट के फासले पे जो भी चीज़ है उसको 20 सेकंड के लिए देख लें, जिससे हमारा आई स्ट्रेन कम हो जाएगा. So this 20-20-20 rule is really important. And Sorry for that. And we should keep our devices at our eye level. Rather than using the mobile like this, we can keep it at our eye level. Even our computers and laptops, we can set their position so that it should not cause any strain on our neck. We should take regular breaks. But if all these tips are not working, then the appliance therapy is required. So posture, we should maintain upright posture. We should take, after every 5 to 15 minutes, हमें pause देना चाहिए. And we should stand and stretch after every 30 minutes if we are working on computer. And we should do corrective exercises because our head is tilted down. हमें chin tucks करनी चाहिए, chin को up करके अपने neck को strain से बचाना चाहिए. And we should do the shoulder blade squeezes, bringing the shoulder blades together. And also, we should stretch the chest muscles and taking the help of a wall or what. So these all small tips which are not very difficult, but I think we should bring it in our normal routines. So to have a balanced life, we should avoid overusing of the devices. See, we cannot live without them. This is fact. So what we need to do, we should avoid overusing it. And secondly, that we should focus on prioritizing our tech habits. We should develop and establish in-person connections and offline activities. We should focus on that also. And we should have a healthy routine life. ये नहीं कि घर में भी बैठे हैं, फैमिली के साथ भी बैठे हैं, तब भी मोबाइल में आंखें हैं, गर्दन मोबाइल में झुकी हुई है. So we should bring some small changes in our routine for a happy, healthy life. Okay, so embrace your journey for refining our tech habits, and you will see this will give a good impact, this will bring your life better. So technology offers incredible advantages in orthodontics, but we must remain vigilant about its potential side effects. By integrating awareness, education, and proactive strategies, we can ensure our patients to benefit from the digital age without compromising their posture and orthodontic well-being. हमने digital age में पीछे तो नहीं रहना, because in this fast-paced growing world, हम पीछे नहीं रह सकते, हम इनके बगैर रह ही नहीं सकते हैं, ठीक? Okay. So, by cultivating the positive habits and by minimizing our negative habits, we should bring our life better, we should make it better, and we should increase our productivity, our well-being, our orthodontic well-being, our dental well-being, our overall health. We should have a better effects. So, technology is not good or evil in itself. It all depends how you choose it, and you should not let it get onto your health. So don't become a slave to technology. Manage your phone. Don't let it manage you. Thank you so much.
Thank you, Dr. Atiya, and I'm sure this was a kind of reflection for all of us. I'm sure we all were thinking how many times, how frequently, and what is the pattern of use of our own cell phone devices. So let me share a little background. When in mid-90s, when computers were brought in routine life, the problems started, documented in the medical literature related to musculoskeletal issues, related to the cervical spine and TM disorders. But the problem, the magnitude of these devices even more and larger than the computers, because computers were used by the computer professionals, but these devices are used by everyone around us. This also opens area for the research aspirants, so we can go for case control studies or even cohort studies related to the use of these stack devices or the TAC neck and related issues. So thank you, Dr. Atiya. Now moving to the next speaker. She's Dr. Rana Nasser Al-Sharkas. Pardon me if I am not pronouncing correctly. She's going to talk about the photobiomodulation in dentistry. This is an interesting area, a therapeutic area for various problems in dentistry, including oral medicine, oral surgery, orthodontics, implants, and more on. Our speaker is a graduate of Damascus University with a master's degree in laser dentistry. She has over 20 years of clinical experience across Saudi Arabia and Syria. Currently, she serves as a clinical supervisor in endodontics and laser dentistry at Syrian Private University. She's an active lecturer and scientific coordinator for international symposia, focusing her expertise on the laser dentistry and endodontics. Thank you. Dr. Rana.
Oh, this is the, okay. And the last one is pointed. Yes, but let me. Assalamu alaikum. I am Dr. Rana. My presentation about laser photobiomodulation in dentistry. I am from Syria. This is most famous mosque in my country, Umayyad Mosque. I wish everybody come and visit us in Syria. Thank you for this generous invitation. Bismillah ar-Rahman ar-Rahim. We all know the history of dental profession, how it was practiced in aggressive way, how it went through stages and developed until it reached the form we are as a dentist practicing today in our clinic. Actually, the Industrial Revolution influenced this profession in one way or another, and developed, it led to invention of devices and technique. Among all these devices, there was light therapy that we are going to discuss today. Light, which is the source of life on our planet, drives all activity in nature. This life enters our body through small packet of energy called photon. What? No. There's problem? This light enters our body through small packet of energy called photon. Actually, studies show that this energy is important for the performance of our body. It allows our neuron to fire, our muscle to contract, and our immune system to fight disease. In America, where average American spends over 90% of time indoor, there are a lack of healthy light, and this leads to fatigue, poor sleep. It is affecting our body balance, and it leads to weaker muscle, decreased mental health. How it started? This one is not new. It was found that in ancient Egypt, they practiced light therapy. Pharaohs used to practice light therapy to treat some conditions, such like vitiligo with turmeric. And by the advancement of the humanity and the science of physics, it also advances. On the 7th century, Isaac Newton found the visible spectrum he identified. Then on 1903, Mr. Neil, he awarded Nobel Prize for his treatment of some disease by light rays. The theory of stimulated emission was explained by Einstein, and this explanation and research led to the invention of laser 1960, and first ruby laser was invented. What is laser? Laser is light amplification by stimulated emission of radiation. We have to know the difference between laser light and ordinary light. There is 3 main differences. First, laser light is monochromatic, opposite of ordinary light, which is polychromatic. Laser light is collimated, that means it is unidirection. Ordinary light is spreading in all directions. Laser light, all wavelengths are on phase, and they are matching like soldier step. Opposite of ordinary light, which is out of phase. This make and can give us laser beam, thin and tight and focused, high intensity energy in small area. Actually, quickly, laser entered dentistry in 1964. To continue this lecture, we have to know that there is 2 main types of laser according to the energy. We have surgical laser, that it is high energy laser, and there is low energy laser. It is the therapeutic laser we are going to discuss today. It was discovered by Mr. Andre Mester. Actually, that time laser was new, and he tried to know what is the effect on laser on tumor. He bring 2 rats, many rats, and he invented tumor cell in wound after shaving the head of the rat. He lased some wound and some wound without lasing. As I told you, he was trying to know what can laser help in treatment of cancer. But what he found, that the hair grow quickly and the wound heal quickly. Then he found the term biostimulation, and he discovered the healing effect of low-level laser. He is the one who gave this name, low-level laser therapy, and from that time it started. Actually, you can find some name, but it is not the true name. You can find soft laser, cold laser, but it is not scientific, and you will not find in any article. By the year of 2015, some scientists, after many experiments of this procedure, they decided to give name of photobiomodulation. This means photo light, bio it means life, modulation it means change. That means we are doing to do change inside the cell. What wavelength we are using in this procedure? Actually, we have therapeutic windows from 600 up to 1200 here. This is the wavelength that we are using in this procedure. It is red and infrared. The red is visible and infrared is non-visible. We can see here 600 up to here 1200. It is penetrate deeply in the skin, so it can reach this area and do effect. Lasers, they are used in this procedure. There is diode laser, there is Nd:YAG laser. This is the wave that deliver this wavelength. When we are talking about laser and its effects, we have to know many words. One of them is chromophore. Chromophore, it's the thing inside the tissue that will absorb the laser, so the laser can do effect inside. As we can see here in the video, this laser will affect, and the chromophore about is color. So no effect in white, no effect in the blonde. You will see effect in this dark color. because there is a chromophore inside dark color and no chromophore in white color. That means laser will not do any effect if there is no chromophore inside the tissue. There is physical, we have to know that when laser irradiate tissue, we have 4 physics. First, if it is reflection, we should know that we don't like to have reflection in our clinic because will come to our eyes. We should, we should know about laser safety when we are using our machine. We have absorption of laser. It is the one who is responsible for surgery. When absorption will happen, so we can do cutting in the tissue. We have transmission. We are using this one in LASIK for surgery eye and in removing veneer in dentistry. We have the scattering, as we can see. When laser scatter in the tissue, it can reach inside deeply and do effect. Here again, we see red and infrared. Infrared is reaching more deeply and red little less. This procedure, there is a lot of articles talking about it, and this article actually increasing year by year. There is a lot of books talking about it, even magazine, because as we talk, there is role in skin health and hair growth. Even now, there is sauna for biostimulation of skin and health. As we can see, there is here many centers, they are giving this procedure. Actually, we can tell that this procedure give the dentist special wings so he can give the patient most than expected if he did not use the laser. This procedure is drug-free and no side effect, non-toxic, and also non-invasive. It is treatment, the cause of the pain, not just the symptoms. If we want to describe this procedure with one word, we can tell nutrition. That means it's give the cell nutrition. We will understand now. Actually, we have something similar in nature when the plants absorb the sun. And in our tissue, there is something who absorb the laser beam. It is mitochondria. The secret is from here. When laser delivered through the tissue, there is mitochondria. The mitochondria is the one who will absorb the laser. There is something inside called cytochrome C oxidase. This one will start working and give 3 main things. It is ATP, adenosine triphosphate is increase the main energy source in the cell. Also, we have reactive oxygen. It is activate transcription factors. Also, we have nitric oxide, increase circulation, decreases inflammation, enhances the transport of oxygen in the tissue. This gives us 3 main effects: tissue repair, analgesic, and anti-inflammatory. So we can have for our patient reduction of pain, reduction of inflammation, helping the body healing itself, also increase range of motion. It will regenerate the bone, the nervous system, everything we have in the body, and there is many application in dentistry. We will talk about it now. Clinical application in dentistry. First, we use this photobiomodulation in treatment of desensitization. In one session, the patient will go immediately with no pain. Also in abscess ulcer, especially recurrent abscess ulcer, there is special protocol that patient will not have this again. And if he has, he will have a smaller and more repeated, the period between the injury it will be more longer. Here, we use this one. You see this child has trauma, broken central and injured lip. No need for medication. So he has photobiomodulation laser on the teeth. He has no pain. And on the wound, so it will heal quickly. No need for any medication. As you can see, it's very acceptable by the child. Treatment of dry socket with no medication. Treatment of angular cheilitis, especially for compromised patient who it's better not to give them more medication. You can use this laser. Herptic lesion, especially when you are using for patient in the beginning, it will heal quickly and the recurrence is very rare. Actually, this using in injury to the inferior alveolar nerve after surgical extraction. Actually, we can use after every damage to the nerve, not only after surgical extraction. Here I have one patient after 3 years from extraction, third molar. He is complaining from numbness and very, very bad sensation. When we apply this laser in specific area, Alhamdulillah, he get 90% become better, and he told me, you save and help me. This is another patient. Actually, as you can see, she came to me. She told me her doctor do extraction without photo before. This is when she came to me. I asked, you have another photo? She showed me that one she did before extraction. You can see it's very deep, and he injured the nerve. So we did for her this treatment. This one becomes 60% better, and still continue. It's used also in mouth xerostomia. You know, this case, it will happen in many conditions, sometimes because of medication, sometimes after chemotherapy. Here is the point where we will put laser, according to the area. We have to know that this procedure is very accurate. There is many things will affect. Here we have the color of the skin. As I told you, there is a chromophore. The chromophore also here, it will be the melanin. So if we have a lot of melanin, we have to increase the laser dose. It is used also in TMG problems. We will apply according to the area. If the patient told us it is going to the back or only up, we can see where can we apply. This is easy case. First time she has muscle pain, finish quickly, but we have sometimes cases, patients severe for a long time, and sometimes not only laser treatment, you should treat with doctor for occlusal. Here the occlusal doctor give her appliance anterior position, but before he cannot start because she was in severe pain. Laser help her to start treatment. It is used also in Bell's palsy. Actually, this is me. I am the one who get this case. And here we can see the point that we are lasing. For me, it was 10 days only I become okay. Here when I was lasing. This is the point. Here there is another protocol. This one for biostimulation, and here for analgesia, for pain removal. This patient, she has Bell's palsy, but it was long time. She told me she did physiotherapy about 50 session and no any and become like this and no any improvement. She tried to do with me. Actually, this result was after 5 session. Here was more, you can see, but after that she left Syria and go. But she was very happy with the improvement. Here when we was applying. Also, we have a lot of cases. There is trigeminal neuralgia. According to the affected area, we are applying the laser in the area. It was proved by articles. It is not only used in dentistry, it's used also in medicine, in many cases, for regeneration in bone, in cartilage. Actually, this is my son after he has operation in his leg. Instead of physiotherapy, I use this photomodulation after he removed the cast. And alhamdulillah, he is very good. We should know that laser radiation is dangerous if we did not use it in correct way, and we have to learn about this one. Wear special eyeglasses. Yesterday I explained in the workshop. To achieve desirable clinical result, we should have good knowledge of laser tissue interaction principles, sufficient experience on laser use, familiarity with the general and basic guidelines of oral diseases and orofacial pain. Thank you.
Thank you, Dr. Rana, for enlightening all of us about photobiomodulation or the low-level laser therapy. And there is substantial evidence ranging from moderate to high level favoring the use of low-level laser therapy in various dental and mucosal conditions. So our next speaker is Professor Harun Shahid Qazi. He's going to speak on when and why to extract in orthodontics. Our esteemed speaker is graduated from Dumont Morency College of Dentistry and completed his training in orthodontics at Marmara University, Istanbul. Currently, he is a prominent orthodontist in Islamabad, known for his expertise in braces, aligners, and dental education and research. He is a fellow of American College of Dentists and is a key figure in regional orthodontics. Dr. Harun, please.